Today we've had the opportunity to learn about first episode psychosis. It's a specialized treatment approach for individuals experiencing early onset of psychosis. And here today to discuss this topic is Melissa Heubner. Melissa is the coordinator of the community support program at Chestnut Health Systems. Melissa has her master's degree in clinical mental health counseling from the University of Central Florida and is a licensed clinical professional counselor in Illinois. Melissa is the team leader of the first episode psychosis program. She's worked for Chestnut Health Systems for 7 years, 5 of which she's been part of the first episode psychosis program. Melissa also supervises the support for seniors program through Madison County with Chestnut Health Systems. So thank you, Melissa, for joining us today. Very grateful for your insight and your expertise. And I will kick it over to you if you're ready.
Yes, thank you so much. Good morning, everyone. I'm excited to present about this program. It is something that I've learned so much just throughout the course of the time that I worked with this program, so much about psychosis, how individualized of an experience it can be, and how important this program is to individuals. It was something as I first came to Chestnut, I'm from this area and just didn't really know a lot about mental health, even though I grew up in a place where access to resources was available. And so it's been really wonderful to be a part of this, to be a part of people's journey, to be a part of that recovery process. I will be bouncing back and forth between 2 presentations. One is some material I provided. The other presentation is specifically from IDHS, just so that way I can make sure I'm providing the exact information that they're wanting to be provided today. So I'll go ahead and share my screen. Right. So first episode psychosis, just kind of starting off with what first episode psychosis is. It can be utilized as a term to describe an experience where someone is beginning to have the symptoms of psychosis. And that is a key feature of the program. Nobody has to have a full diagnosis yet. We just want to see those early onset of symptoms, so then that way we're able to connect and start addressing those concerns. Onset typically occurs between late teens through early 20s. For the program, it is expanded from 14 to age 40. So just because typical onset is between late teens and early 20s does not exclude someone from connecting to services. 3 in 100 people experience psychosis at least once in their lifetime. That fact is something that is included in the manual and in the modules that we provide through the episode of psychosis program, mainly as it's a reminder of how prevalent it is and how psychosis is not always, doesn't automatically mean there's something inherently wrong that is going to turn into a full episode, that is going to turn into a full diagnosis, but more so to normalize the experience. I mean, how often do individuals, if they go without sleep for several days and maybe like, oh, I'm feeling a little bit more on edge, or maybe I'm hearing something that might not be there. That doesn't automatically guarantee that, yes, you meet criteria for a mental health diagnosis. But with that fact, it really helps normalize the experience, especially for family members when we're providing information that it can happen for everyone almost. Early intervention improves outcomes. So the sooner we can connect to people, the sooner we can get them connected to services, the better chances we have to help them get back to that path of recovery that they would like to be on or that we hope to see them on. That doesn't mean that if somebody connects later that there aren't potential positive outcomes. Just the sooner that we can connect, the sooner we can address those concerns. Pre-existing mental health can exist. Some people come to our program and maybe they've had major depressive disorder for years and they've never experienced psychosis, and then something changes and that onset occurs. They can connect to us. So it doesn't mean that psychosis is always the first thing that presents. There can be a lot of things that come first. There are early psychosis kind of warning signs. It's usually a gradual development. It doesn't just occur overnight or come into play overnight. I'll talk a little bit more about those warning signs just as a way to kind of be mindful of, these are the things to kind of notice to be on the lookout for. They can include changes in behavior, perception, thinking, and functioning. Additional warning signs to pay attention to: someone's hearing, seeing, or tasting things that others do not, feeling more suspicious or extreme uneasiness around others, unusual thoughts or beliefs, feeling strong and inappropriate emotions or not feeling emotions at all, withdrawing from supports, sudden decline in self-care and daily living skills, difficult thinking clearly or concentrating, a drop in school and work performance. So these are just some kind of key factors or key changes that we may notice. For some, it can be difficult to determine, is this psychosis, or maybe this is part of the developmental stage. It's common for teens to withdraw a little bit more, to be a little bit more independent, maybe not follow through on self-care activities in the way that maybe parents or guardians may like. But that in itself does not mean it's a warning sign. But if it's kind of alongside all these other factors, then that's something to pay attention to. To break down psychosis symptoms a little bit more in depth, kind of the key pieces of them, we have positive, negative, or other psychotic symptoms. Positive symptoms are anytime there's something, an additional trait or experience. So we think about normal baseline if somebody's experiencing something additionally to their normal baseline. Negative symptoms, there's something missing or an absence of that healthy trait. And other symptoms, mood symptoms can be a response to psychosis. Positive symptoms, often hallucinations are one of the key ones that you may hear. That can be with any of our sensory experiences. So hearing, seeing, feeling, smelling, tasting, things that are not present. A lot of times in media, we will see it represented as seeing a figure, seeing a specific person that's not there. Typically, at least for our program, it's more common for there to be hearing things. A lot of times that can be mumbling. It can be a direct kind of command, a hallucination telling them to do something. If there are hearing things, I've heard it more so as kind of seeing shadows or seeing something out of the corner of their eye, not like a specific detailed figure, but more kind of blurry type of things that are very distracting. Delusions can vary by several types. We have persecutory, so paranoia, worrying somebody's out to get them, that cameras are watching them, that people are listening in to their conversations. Erotomanic, that can be falsely believing a person's in love with them or has those love beliefs or love feelings. Grandiosity, special powers or elevated view of self. Previous to working at Chestnut, right out of grad school, I worked for a crisis unit in Florida, and I met an individual who believed that they were the second coming of Jesus, and were very adamant that that was their belief system. So it's not uncommon that religion can really intertwine with a lot of the delusional beliefs, and that can be really challenging in itself to determine, is this part of their spiritual or cultural background, or is this something that we need to be concerned, or is it both, and how do we address that? Jealousy, belief partner or other people in their lives are unfaithful, and somatic, falsely believing something is wrong with the body. That can present in, there's individuals I've worked with that thought that they were adamant that there was a parasite that they had in their body. And regardless of getting stool samples, medical testing, all that exploration, blood work, all the exploration, that belief was still there. And so that's a really important piece with delusions. Challenging it is not necessarily the best course of action, because of that person, that is the reality. So sometimes we can provide proper education, but recognizing when is it safe for us to gently acknowledge that that might not be the case versus challenging that thought, belief, especially if it feels so integral to their current self or sense of self. There's also disorganized speech or thinking. We have tangential thought. Person has a hard time jumping from topic to topic, kind of following that train of thought. Thought blocking, just getting the words out, being a part of the conversation, being able to express themselves. And word salad, where words are all jumbled up. It's hard to make sense of a sentence, follow the train of thought, and following exactly what the content is of what they're saying. We also have disorganized or abnormal behavior. That includes difficulty completing tasks, impulsivity, catatonia. With catatonia, the person's not responding in the correct or common way that somebody may to external stimuli. An example may be somebody staring at the sun or holding a body position, being very rigid in that body position, even though they don't need to be holding that body position. It can also be like the absence of responding. So if somebody approaches them and the person not responding or engaging with that individual despite having that stimuli. With negative symptoms, we often see decreased emotional expression. We may hear that as flat affect, social withdrawal, avolition, the lack of internal motivation. And it's not just not wanting to do things, it's just there's that desire, that kind of immediate kind of engagement that we may have. We wake up in the morning and think, okay, I need to brush my teeth and wash my face and shower. That motivation is not there or not present. Anhedonia, lack of interest or pleasure. And these can be things that the person enjoyed doing for such a long time, for years. They had a lot of passion with, and then suddenly that's gone. Cognitive difficulties, that really comes into play with those positive symptoms. It's really hard to concentrate and focus and complete tasks when you're experiencing these other symptoms. And anosognosia. It's determined or defined as lack of insight, but it's almost more than that, where it's not just because even if you provide education, the person's not suddenly going to have insight into their experiences. Feels like such a real reality of what they're experiencing that insight is difficult to be present. Like they believe their experiences are what are occurring and what is the reality in those moments. So it can be really difficult, especially when clients are first connecting to our program. That can be a piece that's really challenging, where we're trying to provide that education of they don't believe they have mental health. It doesn't matter if you say, here are the criteria that you meet, it still doesn't feel like that's reality to them, and which can make it very difficult to get them to buy into services if they're not able to recognize they're experiencing mental health. So with that, I'm going to transition over to the first episode program and why it is so important with helping us address those concerns. As I said, the first episode program, so it's throughout the state of Illinois. I heard some individuals from Centerstone, they also have a first episode program. So FIRST.IL is throughout the state. It's funded throughout the state, which really helps us because one of the big pieces, it doesn't matter what insurance people have. We can connect, we can provide services. It's funded through the state. And so that really helps with that kind of first step or maybe thing that somebody might have to overcome. That's not a barrier for services with FIRST.IL. FIRST.IL consists of a comprehensive team-based treatment program aimed at improving the mental health and quality of life for individuals who've experienced a first episode of a psychotic illness. Promotes early identification, also providing best treatment practices as soon as possible. We have a partnership between community mental health agencies. I, as a team lead, will consult 3 times a month with the agencies that are connected to FIRST.IL throughout the state. So not only are we collaborating kind of with the state, but also with other agencies so we can learn from each other, recognize tools and resources, and engage in ongoing conversation of how to best serve our population. We also have that support from IDHS, the DBHR department. And then it was originally funded or created through the Best Practices in Schizophrenia Treatment, or the BEST Center at Northeast Ohio Medical University, NeoMed. They kind of created the first episode program, and it has slowly started to integrate throughout the US. I think Missouri is starting to have some programs. I think Compass Health is starting to provide some first episode services. And so it's slowly growing, which I'm very happy to hear because it's such a prevalent and important program. The main treatment goals for FIRST.IL are to reduce the symptoms of a psychotic illness, to improve individual and family functioning, family supports, engaging anyone that can help that individual and keep them connected to services is a central piece, a central tenet of FIRST.IL. From the get-go, we're wanting to have those collateral information, have people around to help support, because that also betters outcomes. When outside of treatment, you know there's people that are there with you, journeying through the process together. Also to reduce the chance of relapse, promote recovery, and improve long-term course of the illness, to decrease the overall cost of treatment, and to decrease duration of untreated psychosis to improve treatment outcomes for the individual seeking treatment. With the FIRST.IL program, there are 5 different components or 5 different services that are provided. Every client has to connect to at least 2 of these 5. They can connect to more, and they can also connect to other services outside of the main components, but they at least have to be connected to these areas. And with these components, we have staff connected to each different service, and they come from different programs within Chestnut. And we collaborate weekly. Once a week, 8 a.m. every Thursday, we meet and we consult and we discuss clients and how to best support them, which is an amazing piece of having this program, to where we're able to have that ongoing support, because that doesn't always happen. We don't always have that opportunity to ongoing have consultations on, hey, how do we help support this person? Or this thing came up in my meeting today. Can you help them with that tomorrow? But we're constantly in communication, which is one of my favorite pieces about the services we provide. The 5 services we provide, we have psychiatric care, focuses on providing medications, interventions, really emphasize the shared decision-making model. A client is not required to take medications if they do not want to. We, of course, encourage it. We encourage best practice. But if they choose not to, that's okay. What we will also encourage is that they continue to meet with our nurse practitioner, so that way if they change their mind, they're already connected. That person already feels like a safe person that they're familiar with. So then that way we're kind of keeping that option or that door open. We also have individual resiliency training, which is our therapy piece. It helps individuals gain insight into their illness and develop tools for coping, focuses on strengthening problem-solving abilities. We also have supported employment or education, focuses on the rapid return or initiation to employment or education, takes place at community sites. It's driven by individuals' needs and preferences. So we're not going in and saying, this is where you need to work. These are the only places that will provide those referrals or supports to. It's anywhere, any place that they'd like to support in finding employment or education. And we utilize the IPS program, or the individual placement supports model, and helping them find those resources. We also have community support, and this piece is provided by a mental health practitioner. We have a community support specialist. We also have 2 recovery support specialists that provide community support as well, so that we're also paying attention to that lived experience piece. And then they're able to provide kind of differing services of, do we need somebody that's kind of alongside them in the journey, helping navigate the system, validation of experiences, and then also somebody that's able to help with problem solving, connecting to resources, and maybe doing a little bit more of that assessment piece. Through community support, we help individuals gain greater independence, support educational goals and development, connect individuals with appropriate community resources, help individuals navigate complex systems to access needed services, coordinate medical and mental health care, provide education on community resources and supports community integration, offer feedback to the psychiatrist on medication adherence, side effects, and symptoms, and then also provides crisis management support as needed. So there may be times that we're referring clients over to like Mandy and Julie's programs for crisis support. So really utilizing our other programs that might be outside of our 5 main components. We also have substance use counseling, educates individuals on substance use and its impact on mental health functioning, helps improve individuals gain insight into substance use and how substance triggers psychotic symptoms. There's a major overlap between mental health and substance use, especially individuals turning to substances as a way to cope with their psychosis, to numb the experiences they're having. And so we really want to pay attention to that, and we're addressing it with all the different services. And then the last piece is family psychoeducation, which is the primary piece that I provide through our program, providing education about psychotic illnesses and assisting families with problem solving and communications. There are some family members that I meet with weekly or biweekly as needed, providing that education and helping them navigate the changes that are ongoing. It is rarely a linear process of recovery for any type of mental health. And so I like to be a part of that process of helping the family, finding those supports when needed, referring out. Maybe it's, hey, let's check out that NAMI group for family supports that you can attend. Maybe connecting them to their own therapist at Chestnut or other outside agencies. So really trying to make sure the family's caring for themselves at the same time that they're trying to care for their loved one. Typical duration, treatment can last between 3 to 5 years, but there are clients we've had longer. There are clients that we've had discharged sooner. It really depends on individual preferences and needs. Ideally, if they are going to discharge, we'll step them down to just our standard treatment at Chestnut, so they're remaining engaged in services. It's never okay, you're done with this program, so now you're finished with Chestnut services. We always want to have that kind of discharge kind of transition and plan in place. 4 criteria for the first episode psychosis program. As I said earlier, between the ages of 14 and 40 for onset. Diagnosis with schizophrenia, schizoaffective disorder, schizophreniform, or other specified unspecified. Typically, when I receive clients that are referred for the program, maybe if they're coming from the hospital, they might already have a diagnosis, but typically there's not one yet. And so with those, we want to see if they are starting to meet the criteria for any of those standard schizophrenia spectrum diagnoses, but that's not exclusion to services if they're not quite there yet, or they don't quite meet that criteria. Back in 2018, they also opened it up to bipolar disorder with psychotic features, as well as major depressive disorder with psychotic features, and PTSD with dissociative symptoms. The individual can't be experiencing the symptoms for over 18 months, whether it's been treated or untreated. If someone is referred to me and let's say it's been 19 months, we can always kind of talk with DBHR to see if we can kind of make that, kind of waive that. Maybe there were some barriers to them connecting to us within those 18-month time frame. Or if we're able to, we can also connect them with other services at Chestnut or another agency that might be in their region. The person does have to willingly participate. It is voluntary. We cannot force them to engage in any of these modalities. And we're hoping to engage, typically when people first start, they're connected to somebody weekly. So there can be, since there's so many different components, we kind of vary services, who's connected. But as they're kind of stepping out of services, we want to make sure we're still maintaining that monthly engagement. Individuals that might not be appropriate is if there's any type of psychotic symptoms that are due to an unknown cause or a known cause, such as substance use or medical condition. So while substance use can be a co-occurring concern, we just want to make sure it's not substance-induced psychosis and that it's something that's persisting or known from a medical condition. Back in the height of COVID, we had an individual referred to us that had psychosis in response to having a COVID diagnosis. Since there's so much unknown at the time, we went ahead and admitted them to our program, but after their symptoms cleared up, the psychosis went away. And so sometimes we do have to kind of rule out what is happening here. Is this something else that we can address? Which is one reason that it's really great that at Chestnut we have primary care too. So we can also connect them to primary care, get additional blood work or testing done, refer out as needed to figure out if there is something else going on there. Or if somebody, let's say they are having substance use diagnosis or substance use symptoms, we can rule that out, work with the client to see, okay, maybe they're going to connect to our crisis unit, or maybe they're going to go through the ambulatory detox that we have at Chestnut to determine, is this psychosis from something else, or is this from the substance use? Another barrier and reason the person might not be appropriate is if there's any type of intellectual disabilities that impairs with their ability to understand the material that we're reviewing. Something I've seen more and more are individuals that are diagnosed with a dual psychotic disorder as well as autism. And that has created a new challenge of how do we approach and adapt services to meet the person where they are, and when is it appropriate for us to continue to provide services or refer out if it'd be a better fit for them to go elsewhere. At any time, we can refer to other resources. We do our best to adapt and accommodate services, regardless of what an individual may be coming in with. But if from that initial screening they don't meet criteria, I'm happy to refer them and help them connect to other services. For every program with FIRST.IL, we all have a direct phone line for the program. So when somebody needs to connect to me for FIRST.IL at Chestnut, I have a phone directly for that, as does every other agency in the state of Illinois. That really helps us kind of weed out making sure that somebody's not trying to connect someplace else. Maybe they're just wanting to kind of do our traditional outpatient therapy. So that way there's a separate line for original intakes or regular intakes for Chestnut, besides different from the FIRST.IL line. If I'm not holding onto that line, if I'm going to be out on vacation, somebody else within the team is going to have that phone. So we always have access to it to make sure we're providing that support and connecting. Whenever I do engage, I complete a phone screening just to get that initial intake information, rule out known substance use or medical conditions. Of course, in that initial screening, I might not be able to do that, but just to the best of my ability, collect that information and make sure, okay, are they within the criteria of age? Are they within the time frame of onset? How long have they had this diagnosis? And then from there, I will make the determination of whether they should be scheduled with our nurse practitioner, and she'll make that final approval to just determine whether or not they have those beginning symptoms to meet criteria for a diagnosis. And then enrollment is pending until they agree to connect to those two services, their two treatment modalities. On this PowerPoint, there's a couple websites for IDHS with first episode, also ways to locate other resources. And I will provide a couple flyers and briefly show those at the end, but I want to kind of continue with kind of Chestnut's referral process. I wanted to also emphasize that if somebody ever, when they first are referred to us, if they're not interested, we will keep trying. We had a client that for 6 months, we kind of went back and forth where we just kind of waited until if he was interested in that moment, I would try to connect. And sometimes we'd kind of miss and I wasn't able to connect with him at that moment, but then we tried again. And now he's been a part of our program for over 6 months. And he's been connected to, he's engaged with 4 of our 5 services. And so how different of a change that is to go from, I don't know if I want this, to I want everything I can possibly get. And so that's, we really want to be diligent and recognize that sometimes people might not be ready in that moment. And just because they say no that one day, that doesn't mean the next day they say yes, that we're going to turn them away. I get a lot of referrals from hospitals, internally throughout Chestnut. Sometimes I've received them from school systems, other providers in the community. Police officers have sent referrals before. Doesn't matter where they come from, we will connect and screen. Some situations that might lead to referrals that I've seen are like multiple or recent hospitalizations, also like recent school or employment difficulties. If there's been youth that are in high school that had to take a leave from school, that has been a couple of reasons that have led to clients connecting or recognizing, okay, there's something else going here because their functioning at school has changed or they're not able to engage in the way they used to be able to. I included the direct phone line for the FIRST.IL program for Chestnut in here. On the other flyer, as I said, there's individuals from Centerstone here. I have Centerstone's contact info on that flyer as well as for anywhere throughout the state. Anybody can make the referral. So sometimes hospitals, if they call and they say, we have somebody in mind, we just want to learn a little bit more about your program first, I'll provide that information. And then ideally, we'll schedule a time for me to talk with the client or individual while they're on the unit so we can have a plan in place already. So when a discharge comes, they already have follow-up appointments. We have an IMCANS appointment scheduled so we can get all their paperwork completed. And because I've noticed that if individuals, if we don't have that quite yet, they're less likely to engage once they discharge. So having that set plan is really important. Anytime that an individual, sometimes I'll screen them and they'll be interested and then they'll meet with our nurse practitioner and change their mind. So they can also change their mind at any course in treatment as well. And like I said, we'll try again. We'll always reconnect, be open to that outreach. Another amazing piece is that typically for Chestnut, after 30 to 45 days, if there's no engagement, we would close somebody from services. For FIRST.IL, they have 6 months. So for 6 months, we will diligently outreach, send letters, call, try to find ways to connect. If maybe they're connected to somebody else at Chestnut, we'll try to join that appointment to connect and give them that opportunity because we recognize that a lot of times that's a part of the recovery journey. There are those ebbs and flows in engagement. So we don't give up on somebody and we keep working diligently. Right, so then I just wanted to show the couple flyers that I have. So I will provide a copy of the brochure specifically for the FIRST.IL program. This can be provided to other to clients, families, other resources. I welcome you to hang it on your bulletin board at work or any type of shared spaces. I can send paper copies as well if anybody would like to send like their specific address to access. We also have the map for the state of Illinois. You will see there's some areas that unfortunately do not have coverage, but Chestnut and Centerstone has some overlapping in Madison County, but I know Centerstone also provides services in Calhoun, Greene, Jersey, Perry, Jackson, Franklin, and Williamson throughout the state. Chestnut, mainly St. Clair, Madison. If we have anybody on the outskirts like Clinton or Bond County, if there's a way we can still get them into our county for services, then we can still connect. If the person might not be able to come to us, then it makes more sense to connect with our local community mental health, just so that we were not creating any additional barriers. Here's all the contact lines as well for that program or for the programs available. And then also just to kind of show, so for the first episode program on IDHS, it also has all the contact information for each site that's providing the services as well as some of the information I discussed today. And it also includes a little flyer that has all the different agencies and contact info throughout the state.